Hello and welcome. My name is Irina Raiku, and I'm the director of the Internet Ethics Program at the Markkula Center for Applied Ethics at Santa Clara University. Thank you for joining us for the first 2021 event in our IT, Ethics, and Law lecture series. If you'd like to be notified of future events or join any of our mailing lists, please see the link in the chat below. Also, please add your questions in the Q&A section, and we will get to them, as many of them as possible, at the end of the presentation. Today's presentation is AI and machine learning for clinical decision-making, and our speaker is my colleague, Dr. Charles Binkley. Charles Binkley, MD, joined the Markkula Center as the Director of Bioethics after 14 years as a practicing liver and pancreas surgeon and physician leader in bioethics. After receiving his undergraduate degree in classics and philosophy from St. Maynard Seminary, Dr. Binkley attended Georgetown University School of Medicine and completed his surgery residency at the University of Michigan, spending 2 years as an NIH-sponsored gastrointestinal surgery fellow. After his surgical training, Dr. Binkley joined the Permanente Medical Group. At Kaiser Permanente in San Francisco, he was chairman of the Medical Center Ethics Committee, president of the professional staff, and chief of inpatient quality. Dr. Binkley led the clinical ethics consultation service at the San Francisco Medical Center and contributed to ethics policy development and implementation on the state and regional levels. He also served on the Committee on Ethical, Legal, and Judicial Affairs of the California Medical Association, as well as on the board of directors of the San Francisco Medical Society and the program committee of the Society for Surgery of the Alimentary Tract. He is also a fellow of the American College of Surgeons. Dr. Binkley's current work is focused on professional autonomy and the ethical use of AI and machine learning to support clinical decisions. His writings have appeared in the Journal of the American College of Surgeons, Annals of Surgery, Molecular and Cellular Biology, Cancer Research, Verdict, and bioethics.net. Thank you and welcome, Dr. Binkley.
Great, thank you very much, Irina, and I appreciate everyone for attending today. As Irina mentioned, I am by training a surgeon and a bioethicist, and I come at this from the perspective of a clinician to talk about whether patients should be informed when AI machine learning based tools are used to support clinical decisions made by physicians. So this afternoon, what we'll do, first of all, is to introduce these systems and talk a little bit about what they are and how they function. We'll then talk about the patient and who the patient is in their ethical context and the obligation to perform. And finally, as time allows, I'll look at a couple of hypothetical cases. So let's actually begin by considering a clinical scenario. So Mrs. Smith is a 65-year-old female with diabetes. She presents to the emergency room with acute onset of abdominal pain, and a complete diagnostic workup is done, including labs, imaging, a CT scan, and a physical exam. The clinical picture is consistent with an intestinal perforation, although there's no definite proof on the CT scan. There's clinical equipoise as to whether patients like Mrs. Smith should go to surgery or whether they should be treated with antibiotics. The system has access to Mrs. Smith's electronic health record, all of the data, and it recommends that Mrs. Smith be treated with antibiotics. Should Mrs. Smith be informed that this system made her clinical decision to undergo antibiotics rather than surgery for treatment? So first of all, let's have an overview of what these systems are and how they're being used to support clinical decisions. So these systems are being used and being developed in many different areas of medicine to support key clinical decisions made by specialists in those areas. And this is a list of some of the areas in which active research and implementation is being done. And so what are the categories of decisions being supported? So first of all, diagnostic decisions. And these are going to vary based on what the specialty is. Initially, most of the diagnostic decisions being supported are image-based decisions. So for instance, in dermatology, there are smartphone-based apps. The clinician can take a picture of a skin lesion, and the AI clinical decision support system will support a diagnosis. And first of all, is it malignant or not? And if it is malignant, does this represent a melanoma, basal cell carcinoma? And this is based on the system being taught images, correlating images with diagnoses. And so there's a robust data set on which these systems are trained. They're then validated, and experts, so the machine gives a diagnosis and an expert looks at the picture in order to validate the machine's prediction. And so that's done, the data sets involve millions of patients, and then the validation is also very robust before these systems are implemented. Also, in ophthalmology for eye diseases, the image of the eye can be used in order to have the system support a diagnosis. Pathology, a slide of tissue can be used. The system can read, kind of quote, read that slide and make a diagnosis based on it. There are also treatment decisions that are being used by the system. For instance, treatment for cancers. For many cancers, it's unknown what is the best sequence of treatment. Surgery, chemotherapy, radiation. It's also not known for some patients and for some cancers whether chemotherapy is better than surgery or radiation is better than surgery. So these systems are being used to be able to make clinical recommendations for treatment decisions for patients based on characteristics that are contained in the electronic medical record. And in surgery specifically, there are technical clinical decisions that these systems are supporting. Right now, mostly having to do with orthopedic and spine surgery, since those are fixed structures. So for instance, for knee replacement, systems are locating where the bone should be cut in order for the knee to be replaced and how the hardware should be aligned in the knee for optimal functional outcome. In spine surgery, the system is showing where screws should be placed in the vertebral bodies. Instead of having the surgeon make the decision where to place them, the system is saying this is the optimal placement of these screws. And so the decision-making is being transferred, the technical decision-making is being transferred from the surgeon to the machine. And also in other types of surgery, the identification of critical structures that need to be preserved during surgery, the system is being used to identify those. And the overall idea here is that this will improve the quality of patient care. So this is an overview of one of the models that would be used. This particular model is used to develop a radiotherapy decision support for patients with prostate cancer. So many patients with prostate cancer are treated with radiation. There is some toxicity. So this machine, this system is being deployed to help decide which patients should and which patients should not get radiation therapy for prostate cancer based on potential toxicity. So the system has access not just to its training data, but also to data that it may have mined from other patients that it has access to their records in the electronic medical record. Also, the raw data of that patient is fed into the system, the patient's tumor characteristics, its size, potentially its grade, information about the patient, all of the imaging goes into the system. The system then uses its algorithm in order to predict toxicities. And then the patient's clinical record continues to be available to the system even after the decision is made, so that the system continues to analyze things like, was there actual toxicity? Did this improve the outcome? What was the outcome? Did it affect survival? And so there's ongoing data mining even after the decision is made. So the patient both contributes to the system and is the recipient of the system in an ongoing fashion. So what are some of the key features of these systems for our consideration today? So one is the issue of shared agency. So there's shared agency between these machines and the physicians using them. Typically, there's exclusivity in the relationship. So the physician's epistemic authority based on the physician's training, experience, education, gives the physician the authority to make decisions, both decisions regarding treatment, technical decisions, and decisions regarding diagnosis. So does the machine augment or replace the physician? So what does that shared agency look like? Is this like a textbook or a journal article that a physician may look up in order to inform the decision? Or is this actually shared decision-making in the sense that you're introducing a third party into the relationship? What are the intrinsic and extrinsic biases that the physician might have regarding the system that may sway the physician's decisions? And do patients expect exclusivity in these relationships? There's the issue of explainability. So most of these clinical decisions, the machine can't explain why they made that decision for that individual patient. And this is where we get into ex ante and ex post explainability. So the system, you can say how the system goes about making decisions. So you can point to the robustness of the data set on which this system was trained, the experts who validated these systems, the algorithm and the strength of the algorithm. So in general, but when it comes to an individual patient, you can't really say ex post how the system made a decision for the individual patient based on that individual patient's characteristics. And that's an important distinction here in terms of explainability. There's also the idea that because the system can't explain itself in the same way that a physician and a colleague may collaborate in making a decision, the system can't criticize the physician's reasoning, nor can the physician criticize the machine's reasoning since they're opaque to each other. And then even if the machine could explain itself, how would it explain itself since we know that the machines don't reason in the same way that humans do? How would a machine be able to guide a physician through its decision-making, through its recommendations? Would it actually try to be accurate in representing in some way its process? Or would it simply try to get buy-in? Would it simply try to get agreement by convincing, using language to convince the physician to agree with its decision? There's also the issue of transparency in these systems. And it's not just transparency regarding the proprietary algorithm that the company may want to keep private, but it's also what values are encoded or baked into the algorithm. So for instance, there may be priorities other than doing good and avoiding harm, which are encoded into the system. So for instance, increased efficiency, increased profit, even the acceptance of the recommendation might be an encoded value. And we don't always know that. That's not always clear to either the provider or to the patient. So there's this issue of transparency. There's also the idea of the continuous learning of the machine. So the machine is continuously learning based on not just its data set and its data mining, but also the input and the output from individual patients for whom it's supporting their clinical decisions. There's the idea of association half-life, where the association between the data elements that underwrite the outcomes will continue to change over time as more data is gathered. So the idea is that the system is continually changing, is continually evolving. The thought is, teleologically, is that it's also improving. It's doing better each time because it's continuously learning. But then what's the endpoint for proving that? So typically, when we don't know that something is better than what we have, we subject it to a clinical trial. We compare things. And the idea is that if you have something that's constantly evolving, how can you be sure that it's actually better than what it's being compared to if it's always changing? So again, in a clinical trial regarding, so for instance, the vaccines being used against COVID, they're always the same. And we depend on that predictability in order to say, yes, they do good and avoid harm. And then the other idea with these machines continually learning is the idea of standard of care. At what point can you say that they've been adopted as the standard of care if they're continually evolving? Standard of care is not just doesn't just have repercussions legally, but also ethically. So now let's talk about who the patient is ethically and what the obligation is to inform patients. So here are the key sort of ethical obligations that are the context in medicine. And so the primacy first is the physician-patient relationship, and that really frames everything, particularly the power differential between the physician and the patient. So the patient is vulnerable, the patient is sick, is in seeking the physician's help and getting better, and having a diagnosis, restoring the patient's health. So there's an unevenness to the relationship intrinsically. And there's also the historic context that frames this relationship. There's also stemming from the unevenness of the relationship, the vulnerability of the patient, that the physician has an explicit obligation to respect the patient as a person. So this stems not only from the fact that you have two human beings in a relationship that should respect each other and each other's decisions, but you also have this power differential that makes that obligation even more so, that the autonomy of the patient has to be respected. Physicians have an obligation to truthfulness and transparency with patients that extend beyond just respect for autonomy. So truthfulness and transparency, veracity is a professional obligation. Physicians should be truthful with patients and they should be transparent in their decision-making. Patients should also voluntarily participate. They should voluntarily participate not just in their treatments, so we shouldn't coerce patients into a treatment either by lying to them or by misleading them, by making things better to them or enticing to them to participate in a treatment. But in particular, voluntary participation is if we're not sure about something, if we're testing something, patients should know that, and they should voluntarily participate in something that's a trial or that's something that's not proven. Patients should also voluntarily participate in learning experiences. And here, I primarily think about trainees. If a trainee is participating, if a trainee is part of the experience, patients should know that. They should be informed and their participation should be voluntary. And finally, privacy and confidentiality. And again, this is not just a factor of respect for autonomy in persons, but it's also encoded in the profession itself. It's actually part of the Hippocratic Oath that the confidentiality, the privacy of patients will be respected, that physicians won't repeat what they've heard in the process of providing care to the patient. So now let's think about each of these obligations, their conventional application, and then how they may apply to these systems. So we'll start with the physician-patient relationship. So the conventional obligation to perform really prioritizes the relationship between these two people. And the idea is that patients have a choice in who their providers are, who their physicians are, that they can select, and patients select on all sorts of different grounds. Many patients want someone of the same gender, for instance. Some patients want physicians with certain training. And so patients have preferences, and we in general respect that choice for who a patient selects as their provider. Patients also come to trust who their provider is, and that's part of that relationship is the trust. The trust is based on education, experience, judgment, and also who the person is, who that individual is as a human being. So this is a human relationship. Now, there's also some case law that we might find instructive about this relationship and when patients should be informed when there's somebody else that participates in those relationships. So first is the case of Hurley v. Kirk. So Dr. Kirk performed a hysterectomy on Mrs. Hurley. During the operation, he allowed a non-physician assistant to perform part of the operation. He didn't inform Mrs. Hurley about this. Mrs. Hurley suffered complications of the hysterectomy, brought a suit against Dr. Kirk for breach of informed consent. This went to the Supreme Court of Oklahoma, and the Supreme Court ruled that a physician must get a patient's consent before allowing a non-physician to participate or perform part of their operation. Another case is the case of Perna versus Perosi. Mr. Perna saw Dr. Perosi for a kidney stone. Dr. Perosi recommended surgery, explained the operation, the risks, benefits, and alternatives to Mr. Perna. Mr. Perna gave his consent to Dr. Perosi. And Mr. Perna had the operation, again, suffered complications. When the medical record was reviewed, Dr. Perosi did not perform Mr. Perna's operation, but rather his partners performed the operation. And Dr. Perosi explained that this was a very common practice in their group, that if one surgeon wasn't available, somebody else would do it, and they were interchangeable, but he hadn't informed Mr. Perna of that. This went to the Supreme Court of New Jersey, who decided in favor of Mr. Perna and said that it's unethical to mislead a patient as to the identity of the person who performs the operation. So how does this now translate into these systems? So the idea here is shared agency, that that these machines may be participating as a silent third party or an invisible third party in the relationship without the patient knowing. There's shared agency between the physician and the machine. And so what is the extent of that shared agency? So are they just simply just a small factor in the physician's decision-making, or are they actually a fairly large factor? Well, let's look at some of the circumstances that might bias the physician. So first of all, there's the idea of automation bias. So physicians may wind up substituting their own judgment for the machine based on its power. So the machine is going to have millions of patients that it's been trained on, probably more than most physicians. It's going to be highly regarded potentially in the profession. It's going to be trained by top physicians within that specialty. It's going to have been validated. And so there's this idea that automation bias may influence a physician to substitute their own judgment for the judgment of the machine. There's also this notion of standard of care, which we've talked about before, that I think is important to go back to. So if these machines become accepted as the standard of care, then there may be medical, legal, and also peer review factors that influence surgeons, influence physicians to accept the output from the machine, that to follow along with the clinical decision that the machine has made, even in some cases, if they disagree with it, simply because of concern that if they disagree and go against the machine and harm is done, they may be liable for that. As well, payers may require that that physicians adopt the output from the machine, particularly as the machines get validated, as they become the standard of care, in order to be reimbursed. So if you want to be reimbursed, you need to follow the treatment that the machine has prescribed. And also the idea is patient trust. If these machines, if these systems wind up being touted, wind up being promoted, patients may actually come to expect that they participate, and they may ask, they may want the participation of these machines. They may see them as better than the physician alone. And so for all of these reasons, based on shared agency, patients should know when these machines, when these systems are participating in clinical decisions that affect their healthcare. So let's look at the obligation to patient autonomy and respect for persons. So the conventional obligation to inform is based on respect for the patient's right to make decisions for themselves. So what's the physician's obligation here? So it has to do with shared informed decision-making. Patients should know about the risks, benefits, and alternatives. Patients should know about the reasoning behind a diagnosis, the rationale for a treatment decision. And there are two legal standards here. So there's the first is the physician standard that says that a patient should be informed of things that the physician believes the patient should know, which is a little bit circular. And then the patient standard that the patient should be informed of everything that a reasonable patient, a reasonable person would want to know. So how does this apply to these systems? Well, the idea here is that these systems aren't explainable. And the lack of the machine's explainability does not justify withholding from the patient that the machine was used to support a decision regarding the patient's health. At minimum, patients should be informed that the systems are being used to support their clinical decisions and how ex ante, before the fact, the systems make their decisions, even if it's not possible to explain exactly why ex post the system made that decision for that patient. So this is a common scenario in clinical practice where information may be evolving. You may not know everything. There are actually some things you may not know, but you don't withhold it from the patient because you don't know. You don't withhold it from the patient because you can't explain it. It compels you to be even more honest and say, I don't know this, or we don't know the answer to that yet. And if it's something that you may come to know, if it's something that you're asking or that you're investigating, you say, I don't know, but I maybe we will know. And if you don't know and you'll never know, then you say it's simply unknown. Patients, as I was a cancer surgeon, patient would say, how did I get this cancer? And it's a very hard thing to say, well, we don't know. We simply don't know that. But that doesn't excuse me from saying, I don't know, I don't make up something. And so this is the lack of explainability doesn't justify withholding information. Another issue here is the idea is that these systems could introduce a new age of paternalism. So there's been a seismic shift in ethics in how patients and physicians interact with each other in terms of how physicians respect the autonomy of their patients. And this has occurred in the last 30 years. And it's shifted from a doctor knows best, do what I say, I don't have to tell you why, to one of shared decision-making, to informing patients. So to make a recommendation to a patient without informing them as much as possible about the reasoning, including that the decision was made by a machine, would be a failure to respect that patient and a return to paternalism and a shift from doctor knows best to machine knows best. And so finally, let's consider the consequentialist perspective. It's not my favorite perspective, but I think it's important to think about. So using the previous patient with a possible intestinal perforation. So the system recommends against surgery. So let's say that the surgeon was equivocal, may have thought, it's probably better to take the patient to the operating room, but goes along with the system for all the reasons that we've talked about. And then the patient has an adverse outcome. The patient becomes very sick, has sepsis, has to go emergently to the operating room. And the patient says to the surgeon, why didn't you make this decision to begin with? Why did you recommend antibiotics? And the surgeon says, well, the machine told me. And I don't know why the machine said so. The machine's powerful. The machine, they're not going to pay me. They're going to punish me if I'd done wrong. All those reasons. If the patient knows that from the beginning, it's much less damaging to the relationship, both for that patient and much less damaging to the relationship that patients will have with their physician. So the idea is that, and not just because patients should know because you respect their autonomy, and not just because of the consequences, but because you can't withhold information just because it's not explainable to patients. So let's look at the obligation to truthfulness and transparency. So this is based on respect for persons, but also veracity as a professional duty, particularly as conflicts of interest arise. This is probably one of the most salient ways in which this duty is illustrated. Again, we have some case law that may be helpful to think about. The case of Moore versus the Regions of California. So Dr. Moore performed a splenectomy. A physician in the UC system performed a splenectomy on Mr. Moore. He took a tiny slice of the spleen, put it in a test tube, took it to his lab in order to make a cell line out of it. This was discovered by Mr. Moore, and he sued. And the Supreme Court of California ruled that a physician must disclose interests unrelated to the patient's health that may affect the patient's professional judgment. So we have patient's health being prioritized, the influence that other factors may have on a physician's judgment other than prioritization of the patient's health. So how does this apply to these systems? So these systems, again, are opaque in terms of what they're prioritizing. And we know that, it's clear that they're prioritizing not only doing good and avoiding harm, good outcomes, but also things like efficiency, things like reduced length of stay, things like increased revenue capture, and that's not wrong. All of these values can coexist at the same time, but we have to be sure that what's prioritized is doing good and avoiding harm. That has to be the most important. And these other sort of non-clinically relevant priorities have to take a back seat to that. But because these conflicts of interest exist, patients should be informed when these systems are being used to support clinical decisions. And then there's voluntary participation. So we've talked about how patients should voluntarily participate in their care. We don't coerce, we don't force patients into a treatment in general. And that's based, again, on respect for persons. When there are two things that we don't know for certain, which is better, and we make a recommendation to a patient, we explain to the patient that we don't know which is better, and we inform them. So I think about, in my own practice, appendicitis. For many, many years, it was unclear whether antibiotics were superior to surgery, appendectomy for appendicitis. And so there was clinical equipoise. And so if I made a decision for a patient, or I made a recommendation to a patient based on patient characteristics, based on many factors, I would say, we don't know, but I think for you, this is this is appropriate, this is what I recommend for you. So we inform patients so they can voluntarily participate in something that we don't know. They can voluntarily participate in everything, but particularly when we don't know, or when the patient is particularly could be vulnerable to not knowing. So you think about clinical trials, we always inform patients when they participate in clinical trials, largely because the benefit is not proven. They could only potentially be harmed by it. We haven't proven the benefit of things. As well, we inform patients when they're learning subjects, when they are going to be part of the learning process for medical students, for residents. We tell them so they can voluntarily participate. Again, applying this to the AI machine learning systems. So these systems have in general not been validated in clinical trials. And how would a clinical trial be conducted? So you would look at the machine versus the physician versus the machine and the physician. What you'd want to see is that the machine was superior to the physician alone, or that the physician and the machine was superior to the physician alone. So we don't know that. So when these systems are being used without that proof, without that validation, since there's still clinical equipoise, patients should be informed. Patients should be informed when in some ways they are a subject for this study. I mean, particularly say without a defined endpoint, even if it's outside of a clinical trial. As well, because these systems are continuously learning, you can compare them to being in a training environment where patients should be informed that they're a subject for learning and they should voluntarily participate. And so privacy and confidentiality. So the obligation here is, again, based on respect for the person, but it's also a professional duty. And this goes well beyond HIPAA. This goes well beyond, making sure that patients' names and medical record numbers don't get thrown away in the garbage can and people can find them, which is sometimes the way that HIPAA is viewed. This is about really valuing that relationship and keeping things confidential, keeping things to yourself, and only sharing them with other systems or other people that will also keep them confidential, and only for a very good reason. So, and doing it with the patient's consent, letting the patient know that it's being done. So the patient is a health information donor to the system. And there's an ongoing donation as the system not just learns the initial input, but the initial output, the outcome for the patient. And so it's important to inform the patient, even if their privacy is being ensured, even if their privacy is protected, that their information is being shared. There's also in terms of privacy, there's this myth of de-identification that we typically think of de-identifying things as taking a patient's name or their medical record number or their social security number off of something. However, patients are so much more complex than just that, particularly digitally. And so they may be re-identified, and there may be this profiling of the patient with characteristics that get embedded in the electronic medical record, potentially in ways that they're not even aware of. And so simply letting patients know that their information is being shared seems like a very basic obligation that we have. So another way of thinking about this that I find helpful is to think about what are the roles of the patient? Who is the patient relative to this system? What is that relationship like? And I see it as sort of a triune relationship. So the patient is patient qua patient. And this is governed by the physician-patient relationship. The obligation is extended to the machine, autonomy and respect for persons, and truthfulness and transparency. And then the patient is the learning subject. And here, voluntary participation should be ensured by informing. And it protects the vulnerable. It protects the patient. Again, there's this unevenness in this relationship, and it protects the patient because participation should be voluntary. And then finally, there is the patient as bio-donor. So whenever patients make a biologic contribution, we assure their privacy and their confidentiality as part of that, unless they waive it. And so part of that is to inform them. So let's look at some hypothetical cases. I think we have a few more minutes. So we'll go through these and kind of think through them a bit. So this is Mix Lewis. Mix Lewis is a 32-year-old who presents for surgery to remove a mass in their abdomen. So the surgeon has been using one of these systems, an AI machine learning clinical support system that notifies the surgeon of an anticipated intraoperative bleeding event. This is a system that's actually being developed now. So the surgeon informs Mix-Lewis about the use of the system, and Mix-Lewis refuses to participate. Mix-Lewis says, that's okay. I trust you. I don't really want to donate my information. I really don't want you sharing agency. I want this to be just me and you. So I really don't want to be part of this. So what happens? Does the workflow change? Does the surgeon try to coerce, try to prompt, try to engage, try to explain the system further? You take the patient's refusal. What if the surgeon has come to rely on this system to notify the surgeon before a potential intraoperative bleeding event? What if the surgeon the surgeon's skill is decreased somewhat? What if they don't feel completely comfortable? What if one of the expectations of the surgical staff is that they'll use these machines in order to reduce the incidence of blood transfusions, in order to reduce the incidence of intraoperative bleeding? These are all things that are valuable, that are valued. So the use of blood intraoperatively, that's something that we want to avoid in general. So there are all of these questions about what to do when a patient refuses something that we think of as optional at this point. A couple of other issues is what do we specifically inform the patients of? And I specifically have skirted that in the talk because I think this is still evolving, and I think it may actually need to apply specifically to specific systems. What do you need to inform the patient of? The extent of shared agency. Do you only inform the patient when there's disagreement between the physician and the machine, or does that deserve specific here? In general, what we inform patients of are intrinsic risks. So what are the intrinsic risks to the procedure? And so I think about, for instance, gallbladder surgery. Traditional ways of performing gallbladder surgery, you would inform the patient. And then when we started doing it laparoscopically or even robotically, those systems introduced new intrinsic risks that we informed patients of that were in addition to the conventional way of performing the operation. And then the other question is who should do the informing? Is this the obligation of the surgeon, of the physician in that relationship to inform the patient? Is this kind of a blanket statement? If you've ever been admitted to the hospital, there's this blanket consent that you give that basically it defines the relationship a bit, but it says that there may be trainees. If you've ever signed a surgical consent, there's a lot in a surgical consent besides just consenting to the risks of the operation. It informs you that there are trainees that potentially are going to be involved. It informs you that your tissue may be used for research. So there's lots of informing in these documents. They're somewhat boilerplate. So do we just simply put this as line number 17 in these documents and then kind of let it be implicit? And who should do the informing and how should that look? So let's. I think we have about 6 or 7 more minutes. I just want to consider the case of Mr. Henry. So Mr. Henry is a 36-year-old male. He presents for laparoscopic cholecystectomy. So that's a removal of the gallbladder through 3 or 4 small incisions. So there are about 750,000 of these operations done in the US annually. So there are basically 2 critical structures that have to be identified correctly. If they're misidentified and the wrong structure is cut, then this leads to pretty severe complications. The incidence of misidentification of these structures is somewhere between 0.3 and 0.7%. So the surgeon is going to use a video-assisted clinical decision support system. So the laparoscopic camera will be inserted into Mr. Henry. The AI system will be helping identify these structures. So do you inform Mr. Henry that this system is going to be used to support it? And then as a corollary, what if there's disagreement? What if there's disagreement between what the surgeon believes is the correct identity of these structures and what the machine says is the correct identity of these structures. So let's look at this just for a second. So this is looking at this more of as a consequentialist perspective, but I think it has a role to play in this ethical decision and this decision about informing patients. So here's examples of some of the conflicts that could occur. So either the surgeon is correct and the system is incorrect, or the surgeon is incorrect and the system is correct. So let's look at what can happen in a couple of scenarios. So let's say that the surgeon is correct, the system is incorrect, the surgeon goes with the surgeon's decision, no harm occurs, right? The patient's not harmed, the correct decision was made, but the physician's trust in the system is eroded from that point forward. It's a near miss. Let's say that the system's decision was followed and harm came to the patient. Would there be legal liability? So the patient is harmed. The surgeon went with the system. So if the system's the standard of care, most scholars agree that lessens the liability. So if a physician follows the standard of care, even if harm is done, somehow that mitigates the legal liability. But what about the moral responsibility? What about the surgeon abdicating their reasoning to the system? And again, that's a huge moral harm. That's an erosion on so many different levels. We think about the moral distress among providers when they're faced with these impossible situations where there's no good choice. And so this would be one of those instances in which the surgeon potentially abdicated their own judgment for the system and then did harm to the patient. Let's look at it. The inverse, where the surgeon is incorrect and the system is correct. The surgeon goes with the surgeon's decision and there's harm. So what's the legal liability here? Well, again, if the system had been accepted as the standard of care and one acts against the standard of care, there's pretty significant grounds to assign legal liability there. And what about moral injury? Again, the moral injury to the surgeon who was incorrect and went with the system, or who went with the surgeon's own decision and caused harm. And then again, what about the system's decision? The surgeon's incorrect, the system is correct. The surgeon goes with the system's decision and there's no harm. Well, the self-confidence, the professional confidence of the surgeon, and then also the potential deterioration in skills. The surgeon may decide from this point forward, I'm simply going to go with the system. And then the surgeon's judgment, the surgeon's skills may well deteriorate. So I hope in all of this, I've at least convinced you on some of these levels that patients should be informed when these systems are being used in their care. I think there are many different reasons to do that, and also to help you think about how to do this and who should do this and what should be informed and how we think forward. I think if we start to address some of these ethical dilemmas in clinical care that these systems pose before they're implemented, we may well reduce the harm that can be done ethically, legally, and morally down the road. So thank you so much. I really appreciate the opportunity from the High-Tech Law Institute to speak, the invitation, and also the opportunity to be with you this afternoon to think about these things.
All right, so I have some questions, and before I would invite again our audience to post any questions you have in the Q&A. Before we get to the others, have any of these systems already been deemed to constitute the standard of care?
None that I know of, but that seems to be the direction that things are going in. And there's a little bit of debate about how that would look. Glenn Cohen is a law scholar at Harvard who's probably done the most research into this area about the legal standard of care for these systems. So none has been firmly ensconced as a standard of care. I think you would need at least to have a clinical trial to be able to accept them. But as they become ingrained, as they become sort of put in the workflow they may well start to approach that status. And so I think that's the concern, is that we think about what the implications of a signed and the standard of care is before that actually happens.
And a question from the audience: if the physician doesn't understand why the AI system made a particular recommendation, how does the physician explain that recommendation to the patient?
So this happens all the time in clinical practice. So for instance, so let's walk through a cancer diagnosis. So a patient gets a biopsy. I read the pathologist report that it says cancer. I go in and I talk to the patient and I say, I'm sorry you have cancer. And the patient says to me, how do you know? Well, I disclosed to them, I informed them. Well, my colleague told me. Well, how does the colleague know? Well, I can, again, kind of the ex ante, comparing this to the machine. The pathologist has lots of training. He or she has seen thousands of these. He or she is excellent at what he or she does. But I can't explain to them, for this particular patient, this is exactly how they saw this cell and this cell. So I may not know the sort of ex post explanation, but I still inform them as much as I know about how the decision was made. And I also inform them about what I don't know. So I can't explain everything, but I explain to them what I can.
Okay, this is another question from the audience. Can you speak to the de-skilling issue for surgeons? Could the surgeon not learn from the system instead of being de-skilled by it?
So I think about this as an asymptote, right? Where you've got the line approaching, and at what point do you say that the line has gotten close enough? And so this is a question, in training of surgeons, is at what point do you say that the trainee can operate independently? So the notion is that there's only incremental improvement in one's skill, one's experience after they finish their initial training. And so there is the opportunity to learn from the system. The greater concern, though, is that the physician will come to rely too heavily on the system, particularly subjugating their own judgment, that there won't be this need to continue to develop your skills, to continue, particularly since the system, if there's disagreement, you don't know why you're wrong. Or why you're right. So the system could be right for the wrong reasons. I think about, there's a case of a system that was deployed at Mount Sinai in New York to be able to predict, based on chest x-rays, which patients were at greatest risk of clinical deterioration. And so it performed marvelously. It was absolutely brilliant. It predicted every chest x-ray. It predicted accurately from the chest x-rays, these are the patients going to deteriorate, 98% accuracy. Well, then they deployed the system into another part of the hospital, and it was abysmal. It couldn't predict which patients were going to do well, which patients weren't going to do well. And so they stopped the system, they did a postmortem. And what they found is that the system wasn't identifying which patients were going to do poorly based on their chest x-ray, but rather based on what machine was used to take the x-ray. And so certain sick patients in the hospital are kept in certain areas, and this same machine was used to take the x-rays of all the sick patients. And so the correlation was the right answer, but for the wrong reason. It wasn't based on any clinical characteristics. So there is this opportunity to learn. I think that there are some barriers to that, and there's also this concern of de-skilling. And the de-skilling is not only in medicine, but in other areas where these systems are being introduced.
Absolutely. So following up on that a little bit, is your sense that right now physicians are too trusting, too ready to follow AI recommendations, or too reluctant, or neither?
I think there's some ambivalence. I think they're hesitant. Physicians as a group can sometimes be hesitant to adopt new things. Like, we're so, the idea of doing good and avoiding harm, proof, people have been very frustrated with clinical trials around COVID. Why don't we just, use this? It's been shown to be somewhat good. Irina and I actually had this discussion about using anticoagulants in COVID in patients with COVID, and she asked, why don't we just do it? It seems like it's going to, well, we really want this empirical proof, right? We want to know that it's going to do good and avoid harm. And we want that to be proven before we want more than just a sense. And so I think physicians are a bit divided. I think there's some physicians that say, it's a bit like Pandora's box. They're not sure exactly all the repercussions, both ethical and also for the profession. And so I think they're hesitant. I think that these sorts of discussions will go a long way toward restoring confidence or providing confidence. We're very seldom convinced of things. Well, sometimes it takes more than just showing people proof. They really need the buy-in. And I think showing people that these systems can behave ethically with patients and they can actually support patients and can support physicians. I get back to this idea of at some point, patients may want to know that these systems are being used in their care. I had a pediatric surgeon from the University of Michigan come to my class, my ethics class last night to talk about deciding which neonates to put on this life-saving intervention called ECMO and which not to. And I kept thinking, gosh, it would be really great if we taught these systems to be able to predict which neonates will do well and which won't, and help make those decisions. But then you start thinking about that. And so how would that look? How would you come to make these decisions, for these patients? And then how much trust do you have in those systems? So I guess that's sort of a roundabout way of saying, I think it's still an evolution.
Okay. In terms of how to communicate some of these things, this is again a question from the audience. We know people in stressful situations don't hear or absorb what they are hearing. Are there additional obligations to ensure comprehension when using AI and machine learning and trying to explain that to people who are about to sign whatever consent form you put in front of them, right?
Right. I think that can work on both sides. And so if these systems are embedded in stressful situations, again, going back to my colleague last night from the University of Michigan, a pediatric surgeon, these infants, these neonates are born, and if you don't put them on this system that provides oxygen to their brains, they deteriorate very quickly. And so, as she was saying, we can't oftentimes get consent because it has to be done so quickly, and this is an emergency situation, and we explained it to the family afterwards, kind of implied consent in emergencies. So if you have a system like this that is embedded in these emergency situations, the physician oftentimes isn't going to have time to really ponder it, to weigh the different, particularly if there's disagreement. And so there may well be the sense of, I'm just going to go with the system. At the same time, patients may not necessarily, there may not be the opportunity to robustly inform them of everything, but I think at least knowing the presence of these systems, and then there are also going to be some decisions going to be higher risk and lower risk, and there are going to be some systems that are going to have more or less influence. And so this idea of shared agency, and my sense, and this will probably be the next talk, is that as the agency between the machine and the physician increases, there's a greater obligation to inform. And as the risk, as the automation, or as the autonomous functioning of the machine and the risk that it could impart grows, so should the informing. And these are the two axes that the FDA is looking at in terms of how to regulate these machines. What is their ability to perform autonomously, and what is the harm that could come?
So I'm already looking forward to that next talk, but we have time for two more quick questions. These are both from the audience. Will insurance companies play a role here in terms of liability of AI and ML costs and the interplay between physicians and those systems?
So I think payers rightly have a huge role to play in these systems, and I think it's in two ways. So I think there's a huge opportunity for these systems to reduce variation in treatments. So when I think about my own practice as a pancreatic surgeon, I would see lots of patients that had either been misdiagnosed or had been misinformed. I'd see them in second opinions. And so, not all eggs are equally oval. And so people are going to have different perspectives, people have different skill sets, people are going to have different biases. And so trying to at least make that somewhat better. It may not be perfect, but trying to make that better, trying to reduce the variability, trying to make sure that the quality standards are met in a systematic and methodical way it has a definite role. And so I think that's part of the obligation that payers have to their patients, is to say we're gonna ensure that your quality, the consistency is as good as possible. However, at the same time, patients need to be informed, and particularly when there are competing values. I think the obligation within that industry is to say, we have these different priorities. It's fine for all of them to coexist, but if there's a conflict between efficiency and doing good and avoiding harm, we prioritize doing good and avoiding harm. If there's a conflict between an outcome and abbreviating length of stay, we always prioritize the patient, not these secondary non-clinical considerations.
Another key question here: how do you envision human bioethicists fitting into the interaction between physician, patient, and AI and ML?
So I think it's a great question. I think it's in a number of different ways. So I think first is thinking ahead, like we're doing today, thinking about policy, really being part of the deployment process. As these machines are being deployed, one of the questions that health systems are facing is, where do we house oversight? Are these kind of innovations, and do we put them in the innovation department? You know, who's part of the deployment? How do we audit them? Are we just auditing them for validation that they're functioning like they are saying they will, or are there other issues? So I think the bioethicists have an important voice in that whole from inception all the way through deployment and then auditing, because we think about things slightly differently than maybe the engineers do, and so I think they have a huge role there. I also think they're going to have a huge role in clinical consultations, particularly if there are systems that work on the allocation of scarce resources, particularly end-of-life decisions, allocation of resources within critical care units. Also within mass casualty situations potentially. So as these systems are making some of these key moral decisions that have typically been under the authority, the epistemic authority of physicians, I think that bioethicists are going to have a role to play in sort of bedside clinical ethics in assuring that the patient's autonomy is respected, that all these other things that we've talked about, that the relationship is respected, that there's veracity, there's truthfulness and transparency, that their privacy is protected, and all the other things that we've talked about. And not as a police, not as sort of this judicial arm, but rather in robust relationships with all the decision makers and stakeholders.
And I'm going to apologize. We have lots of very good questions that we haven't gotten to. I think you can all find Dr. Binkley via his email through our website and ask your questions. One key one that we haven't talked about, and I think we can do a whole separate program on it, is, do you see AI as improving or worsening that systemic racism that sometimes affects delivery of care? And maybe if you can just give a very short answer to that. I realize it's not enough.
I think that's absolutely great. I think it's a great question. I think both from the perspective of training data. So we know training data needs to be deliberately diverse. So that's sort of an easy piece thinking about bias. But we also need to make sure that these particularly the clinical decision support systems are, if they're shown to improve care, that we apply them equitably. That we don't just put them in the large hospitals where there are lots of whistles and bells, but we make sure that everybody has them throughout the health system. This could be a real opportunity to raise the quality of care. We know that there's disparate care between public and private hospitals, for instance. And so I think this would be a huge opportunity to really improve the quality of care. We have to instill trust. We have to validate these systems. We have to ensure that they're doing good and avoiding harm, and all of those things. So I think this is a key issue, not just in terms of racial biases, but also just in terms of the healthcare system in general. I think it really is a pivotal point. And if we do it well, I think this could be a huge advance in patient care. I think if we do it poorly, it could be a real setback.
So if we were doing this in real life, I would now ask you for a round of applause for Dr. Binkley. Since I can't, I'm just going to thank him on behalf of all of us. And thank you all for joining us. We look forward to seeing you at future events.
Great. Thank you so much, everybody.
Thank you.